Let me ask you this, and with a caveat of these were really beautifully done phase 3 global trials, blinded, double-blinded, prospective. And so we look at the AE profiles. And the drugs have some differences, right? There's some molecular differences. And the AE profiles, not in comparator studies, but they did show some different things. So let's talk about that and your sense of the differences in profile and how you would make a decision with your patients.
Yeah, I think AEs are always going to be important when we choose drugs for treatment of this disease. Since we have 3 options, we might as well have those conversations with patients and certainly think about it amongst each other and ourselves too. This patient was started on darolutamide. I have a feeling that probably had something to do with the AE profile and also probably because of his history of seizures. So it's really important for us to acknowledge that the PROSPER trial, I know, did not allow patients in with a seizure history. I'm not certain about the SPARTAN trial, but the ARAMIS trial studying darolutamide very clearly included patients who had a seizure history. And the other thing I think about in addition to AEs, and I'll get there, is these drug-drug interactions that are so important for my patients who end up being older men who often have cardiovascular comorbidities and others. So I think about that in addition to AEs. The AE profiles I think are really difficult to compare across trials, and I really want to hear everybody's thoughts on this because we've seen some people try to do that, and I think there are definitely problems with that. But what we can do is look at the AEs as compared to the placebo arm in the trial, and we saw that there were a couple things that stood out in the SPARTAN trial, maybe monitoring for hypothyroidism or the development of that over the course of treatment, and then there's some level of patients developing rash as well. Certainly enzalutamide looked very similar in the PROSPER trial to what we have seen, so there were some patients who developed seizure, I believe, as well as some patients who noted fatigue, which we know is potentially associated with enzalutamide. In the darolutamide trial, it looked to me, especially when adjusted for time on exposure, that there was a relatively lower risk of side effects, though things like fatigue still happened. It didn't seem to be that much different than the placebo. But I am always cautious to actually compare these AEs across trials. And again, just eager to hear what your thoughts are.
Well, and I think Neil said it. We're blessed with all these riches of these all 3 drugs. So that also gives us some ability to counsel patients. Oh, if you have a history of seizures, you have a history of ischemic heart disease, there are other things that we can do. You don't have to always just shoehorn someone in or give them something that really exposes them. So I think the other thing is as we talk to patients about, hey, these are your options, we can say if you experience this fatigue or cardiovascular or whatever, we have something else to move you to. And I think that gives them great comfort as well. So we have all these different options.
Yeah. So let me be provocative. Just imagine me, without a healthcare background, coming to you, Neil, or you, Alicia, you can, and you talk to me about my state of disease. You tell me there are 3 oral agents. You're still debating between yourselves which is the oral agent of choice for me. The last thing that I want to even think is about, and there is controversy within the field as to A, B, or C. So I actually, to be provocative, I actually do not talk to my patients. I tell the patients there are 3 oral agents out there, and I'm going to make the decision based upon your needs. But I usually do not. I may have mentioned their names, but I don't give the patients data about the 3 agents because I think it's just way too much for a patient, to be honest with you, to process, at least in my opinion. I think that also, let me just speak on the CNS toxicity and the seizure issue specifically. So when enzalutamide got approved in the AFFIRM data in the post-docetaxel space, right, and then moved into the PREVAIL data in the pre-chemotherapy space, we recognized that the incidence of seizure was around 0.9%, less than 1%. To me, when you look at the impact of outcome of this oral agent against the toxicity profile of having a seizure episode, to me is meaningless. However, we now have data that actually demonstrates that actually with the upward data, which is Mike Morris's and Susan Slavin data, that included patients at risk for seizure activity, and the risk of seizure activity with the enzalutamide was still no different than before. So I'm not sure that seizures for me is the big distinction here. I think the neurocognitive dysfunction that I do believe is underappreciated with enzalutamide is perhaps to me, one of the biggest concerns that I have. AR inhibitors, and we know that from the high-dose bicalutamide era in the 80s and 90s, can lead to hypertension. So I think dollar for dollar, if you allow me to use that expression, I think hypertension and cardiovascular issues not only are related to a lack of testosterone, but also to the AR inhibition. I think the concern that I have with falls, fatigue, and neurocognitive dysfunction is real. And I think there is a unique difference in those across the agents. You mentioned that, Alicia. You know, obviously with APA you have rash, hypothyroidism. Enza doesn't do that. With darolutamide, you don't have the rash. You have a little bit of less incidence of hypothyroidism, but because how daro is structured chemically, it doesn't penetrate the brain barrier, it doesn't compete for GABA receptors in the CNS, and therefore you do see a distinct difference between the three oral agents. I am a bit biased because, and I know, Neil, you also participated on the darolutamide development, and I think that I do see a significant difference, at least in my prior history with darolutamide. So when you look at that, I think that, yes, the seizure activity may actually excuse you to do APA or daro, but I think that we underappreciate the cognitive dysfunction that our patients develop. And I know, Alicia, you, through your interest in quality of life and PROs, we've been trying to push that agenda that we really don't understand cognitive dysfunction that well. We don't know how to measure. We don't know the baseline. Lack of ADT alone can give you those side effects. So I think it's complex, but I do agree that most of us will actually end up selecting an agent based upon our comfort zone and the understanding of those side effects that have been presented in the trials. But I agree with you, there is a complexity in how you understand the three oral agents, and I don't want people to actually believe that you can compare across trials because that cannot be done.
Yep. So I love the provocative nature of how you began. Let me tell you where I think we're going in the next months to years. And we're all starting to do this work. Alicia's been pioneering this for quite a long time. You're absolutely right. It's the spectrum of neurocognitive. It's not just seizure, which, by the way, APA and Enza excluded in their studies patients with seizure. And daro was interesting. Those patients in early phase to phase 3 ARAM has never been excluded.